Welcome to a Cisco meeting. You are entering the meeting now. This meeting is being recorded. You are the only participant.
officially meeting Bartley.
Hi.
Thanks for seeing my daughter.
Oh, yeah.
Yeah.
Did she go okay?
Yes, you hear what I had at the end of that story?
Yeah.
She went home Wednesday. I left her on Thursday.
Yeah.
It was still kind of busy and not great.
Uh-huh.
Took her to the pediatrician on Friday, and the pediatrician asked her, well, what did all this start? She's like, well, when I was skiing last weekend, I fell back and hit my head. And
oh, no. So she has a concussion.
Like 5 days, didn't think we'd tell anybody that. But yeah.
Well, I'm glad she's doing it.
So she's better.
Okay. Yeah, it's nice to meet her.
Yeah, we went, once I finished the OR here, I went over there. I said something about you. So we nice to be at your patient. No, yeah, I got it. All right. We got Hey, Barbara Turner, Kelly Lee, Roy. All right.
I did have to use my Oh, do you have any now? Yeah, we need to go to Alpha.
All right.
Not really sure. I just want to keep watching it. What? Still like them. She's dressed as like fake. So I was like, yeah, I appreciate that. I was like, I don't want to look like that. And they were like, your hair was, either we're going to put 12 inches of your hair. And I was like, what? And they were like, your hair is super short. Her hair is super short. And I was like, are you sure? And of course, this is like a hairdresser. And I was like, well, actually, I'm going to tell you this. And it was actually really good. It took way too long. Like, it took like twice as long. It was like 2 hours. From like 8 to 10. But it was not really like surgery. Like, he would do something, he'd be like, no, stand like this, stand like this. And then it's not to end up doing like 75%. But they did a really good job. I was really impressed. I was like, wow. Cool. But I didn't realize. Yeah, how long my hair was. It's kind of interesting. Yeah, I think they're worried if they don't, but they are. Right, that's the thing. Well, maybe it wasn't busy too because this guy like was essentially just staying there constantly. Oh no. Yeah. I'll give you that. And he was like, he was so stupid. I was like, I not slept this little my child.
Oh, yeah.
Oh my god. My turn.
Long time no see. You still been playing?
I blend that in, and then Sean will text me like, hey,
The last thing you need to do.
I took some of it
Our
out.
dad guilty me into it.
That's great.
It's like been like 6 months since I've been there.
yeah.
And I went and there were like 4 people total. I'm like, listen, I am old and average age. This is not compatible with life.
Yeah. I'm holding on for you.
It's wrong. So
She's loving it, man. Are the two things here? That was my
all right, good morning, everybody. We'll get started here. We have Dr. O'Loughlin's talk to get to after a few announcements. I'm a little confused because it says here on the screen my name. You guys have to figure that out. Your name is my name. Anyway. So quick announcements real quick. Friday is ski day. Everybody made it to the app site. Okay, I guess we'll find out in a few weeks. But day starts around 9 o'clock in Solitude, or earlier if you make plans, whatever. And then there's dinner reception at Squatters downtown at 6 o'clock that evening. So next week for Grand Rounds, we have Department Grand Rounds, which is in the other auditorium in the other building at 7 o'clock a.m. Gary Dunning, who's from Indiana, will be here discussing the aspects of building a surgical culture of education. The following week, we have Dr. Gutnick doing our Chief Resident Series continues. And then the following week, I guess February is education theme because Roy Fiddy-Yaghorn from Harvard will be here, and he'll be discussing the power and balance between resident autonomy and patient safety. Also for faculty and any residents interested in education as part of a career track, there's going to be a symposium on Tuesday evening in the AltaView conference at 5 o'clock that afternoon. Will be on giving and receiving constructive feedback. So I highly recommend that to anyone who's interested. So we have Dr. O'Loughlin this morning. Jim says he states he is the oldest resident. Yes.
So you said Squatters, you said Watson.
I looked downtown. It's the one downtown next to whatever it's called. Vultures. I looked online last night. It was listed as one in one place and one. It was listed. It's listed as squatters on Google Maps.
We'll get it clarified. This might be important.
Yeah. If you show up and there's nobody there, go to the other one. And it's not the one in Park City, so there you go. Not the one in Sugar House. So, but yeah, we'll get that clarified. So Dr. O'Loughlin is the oldest resident of the program, so he says he has many rich life experiences to share with us. I guess that's since Dr. Baum graduated. So Jim was raised in Iowa, but then migrated south to the University of Florida for undergrad and grad school, where he earned his master's degree in electrical engineering. He worked for the military for a few years developing weapon systems and decided to switch careers and attend medical school, which he did in Rocky Vista University in Denver. He did an intern year at the Naval Hospital in San Diego and then moved here as a categorical resident. He and I actually started at the same time on the same service, and I was tremendously impressed with his work and was reading about him in the GEC meeting, and then that's when I found out he had a warm-up year. But he still did okay, so give him credit for that. From a personal standpoint, Jim and his wife have made the most of exploring Utah outdoors. They have a son who's about 5 months old. And then some of other Jim's miscellaneous accomplishments are that he is the reigning residency chess champion and ping pong champion. So I think the gauntlet has been laid down. So when he finishes this summer, he's headed back to the Navy on an aircraft carrier in San Diego. And so we welcome him as he presents telesurgery where we stand.
Thank you, Dr. Brown, everyone for the opportunity to be speaking here today. Today I'm going to be talking about what I think should be a growing trend, and what actually is a growing trend in medicine and surgery. Before I get started, though, into my talk, I'm going to elaborate a little bit on the intro, just to give a little bit more background about myself. Most people here, I think all people here, obviously now, know that I'm destined for the Navy come July. A lot of people these past few weeks have been asking where I'm going, and I just found out last week. I thought I was going to be going to Northwest U.S. up near Washington, up in Washington. This ship used to be stationed in Washington. That's where I was headed, but this ship has changed home port, so I'm headed to San Diego instead. So it's kind of fun. I'll be part of a searching for a carrier strike group. This ship holds about 6,000, and the ancillary ships around it hold 1,500 or so. So if anyone gets a phone call from me at 2 in the morning, 8 to 12 months from now, please answer it. I'm probably in trouble now. Just to add a little bit to my background, I did go to the University of Utah. I studied engineering. A big part of what I studied was network design. Think of the optimized flows of information, usually information, but through a system of servers. So generally, internet, telephones, that sort of thing, on a high traffic network, trying to optimize the flow across it. And I always thought it was kind of interesting. I don't know what made career. I always thought it was interesting that you could apply these same systems to networks of people and trying to get them to flow through systems and servers. So this is actually one of my favorite examples. This is how just lines form. Classically, when you go to the grocery store, lines might form in just individual queues at individual stalls. This is the optimal way to do it. Grocery stores don't do it though. But one big line that feeds into individual lines. And queuing systems is the way we manage people and let people flow through systems has always been kind of an interest of mine. And that feeds a little bit into how I came up with this topic today. So that's my background, and I'm going to sort of meander a little bit more. Sorry. I remember sitting over here in the front row 4.5, 5 years ago, and this was back when internship was hard. We had to come up every week from IMC, every single week, not every other week, in the hard old days. And I remember driving back one day after watching the grand rounds, and I was riding back with Dr. Barline, if anyone remembers him. A sage, old leader of our crew. I asked him. We're asking him, what should I do? Like, I can't think of a topic. I'm nervous. What do I do? And Bartline puts his hand on my shoulder and says, Jim, just pick something you're passionate about, and your talk will write itself. So I've been a clinical resident for 5 years now, and it sort of crushed the passion right out of me. You can ask my wife. So it turns out Dr. Bartline's advice wasn't that good. I should have guessed. So I kind of spent a little bit of time about a year ago kind of mulling over this topic. What should I do? This isn't working. I need inspiration. So I happened to find a quote from an even older, even wiser leader, operator. And he goes, use your aggressive feelings. Let the hate flow through you. That's Emperor Palpatine. And it sounds like a joke, but it's really pretty good advice. I'd recommend it. Take it. If you want to find a little passion, just find what makes you mad in the day and see if that doesn't help you. So that's the advice. I started walking around with a notepad, stomping around, getting madder and madder, and just writing down what was making me mad. And maybe one of these things would be able to give you some guidance. So some things that made the list was pages. Get a lot of, remember being an intern thinking, why are you getting mad about pages? I love them, it keeps something. And now, like, just the sounds, the first beep is enough to, like, make my blood pressure go through the roof. So, but it's not really the grand topic to complain about that. Once again, thank you, sir, for the opportunity to be admin chief this year. Not a day goes by that I don't get a little passion from your guys' requests and coordination challenges. But again, not the best grand rounds topic. It's sort of self-serving if it was. Every day I feel a little passionate when I park in my designated parking spot that I paid $500 for. It's 3 miles one way, 3 miles back through the snow. But grand rounds and parking, that's not really good. So I could go on and on, but I don't want this to go a gripe session. I'll kind of skip to the point. There was one thing that happened last spring, summer, that really got me going. I figured it would be good for this forum. But before I do, I really do think this was a good way to go about it. Think about what makes you mad, and that might be a problem you can solve. So that's my life advice for you, Marcus. All right. So what got me so mad and so inspired that I was going to come here and talk to you guys today? This is Wyatt James. He was born in September. He doesn't make me mad, but the process of bringing him into the world put me on the other side of the doctor-patient line. This little jaundice, not but I clearly remember going to my first OB appointment, my wife's first OB appointment. We waited a couple weeks to be seen. We drove in, fought traffic, really fought for a parking spot. It's really terrible if you guys have ever tried to park in patient parking in the middle of the day. We showed up what we thought was going to be early, but rushed to get there just in time. The receptionist can't tell us if our insurance is going to be accepted or not, or if we have to pay for this meeting. Some 4-year-olds like coughing on me. And all this, and we finally get back to the patient room, and no physical exam. It was just kind of a care coordination meeting. And I remember just walking away, like thinking, this was a lot of work to get here, and this was an 8-minute, 10-minute discussion. And this really could have been a telephone call, you know? We could have done this and saved me a lot of time and had a headache, and I would have been just as happy. And I presume my wife would have didn't ask her. So that sort of got the ball rolling and thinking, are we doing this to people? Am I the only one this is happening to? And I can kind of think back through clinics over the weeks and years where people come in and we do this to them. We didn't get the scan we should have, we didn't get the lab we should have. We could have helped them over the phone or post-op visit, that sort of thing. And I think we could do a little better. One more example. This is a nurse that works in the hospital. I've anonymized him. But he's a pretty savvy guy. And I overheard him telling a story that I was going to repeat here. He called his PCP a few weeks ago, and he said, I've got this lesion on my head, it's growing, it's bleeding, I'm nervous about it. He emailed a picture in, and I've saved you, this is actually a pretty high-def picture, I've saved you the trouble of, you don't have to look at the big version, but he emails a picture in, the care coordinator says, oh yeah, this is something we can treat for you here. Come on in, we can have for you. End of the next week, the patient comes in, sees his PCP, and the guy takes one look at it and says, oh no, this should be in the urgent care, they're in urgent care. And I just think that's garbage. Like, the guy did all the right things, he's a savvy person, and he shows up and gets one quick look and sent away. I think we can do better than that. It delayed his care, wasted his time, wasted money, and it just shouldn't happen. So, I can go on with examples. I think for the most part we're pretty good. Most of us screen our clinics, most of us are looking for opportunities to not make people come in. But I think there's an opportunity to do more with this. Let's see. And my kind of aha moment and what really kind of drove me to want to talk about this was when my brother called. He called me last late summer, I guess, and he wanted to chat about medicine. I'm sure we all get phone calls, like even since we started medical school, you get the phone call from the old friend, the old neighbor, whoever, and they want some medical advice. And I got one of those phone calls from my brother. He wanted to know, his kid had this barking cough, worse at night, maybe struggling breathing, and he wanted to know what he should do. And honestly, didn't really have much of an idea, but light bulb goes off. Like, there's no reason I shouldn't be able to, if I was a competent pediatrician, I should have been able to tell him exactly what to do. So, I can see the kid, I can hear the kid. Anyone should know this is a croupy cough with any kid who's doing okay. It kind of made me realize this is how I would like to be seen. If it's at all possible, this is the way I would like to be seen by my physicians. Physical exam, notwithstanding, if you can wait or if you can get by with this would be my preference. So this really got my gears turning. As a recent healthcare consumer for the first time, this is how I decided I want to be seen. This picture kind of demonstrates that this isn't a new idea. This is from 1924. It was the cover of a magazine called Radio News Magazine, and the artist has depicted what they thought was the future. It's a physician there on the TV screen who's looking at his own screen, looking at this little kid that's opening his mouth to show the doctor what's going on. So 100 years ago, people were daydreaming about the fact that the possibility of getting care in this way. I'm pretty sure, I bet just about 100% of this room I could call right now and do a FaceTime call. And we have this magical technology, it's in our pockets and we don't even really employ it. So why don't we do it? Well, you can't do an exam that well, it's true. You can't bill for it that well, it's kind of evolving. And we're kind of concerned that patients don't want it, but it turns out that's not true. I think the biggest reason that this isn't done routinely, that we're not busting out our cell phones and just chatting with folks routinely, is that we were kind of trained, all of us here have been trained in a system where we just don't routinely do it. This is evolving technology is relatively new, but we can do it now, and I think we should try to think about it a little bit more. So, what is telemedicine? So, before I go on, I don't think it'd be a grand round if I didn't define some word for us. So, it's part of the very passive. This is a fairly broad term, telemedicine. It's just the diagnosis, treatment, or management of patients by means of telecommunication. So it's such a broad term that it's hard to get your arms around it. When I think of it, I think of a physician and a patient just engaging each other over either the phone or video conferencing. But there's a huge array, anywhere from the surgical team. We've all heard the story of the New York surgical team that took out a gallbladder in France across the Atlantic Ocean. That's technically telemedicine or telesurgery. I don't think we're going that way, but it's an example. Every time someone calls the transfer center, there's a doc talk about how to manage a patient. That's telemedicine. Patients getting their results over my chart is telemedicine. Coordinating emails, sharing pictures. It's such a broad term that using any technology to make any communication. And really, at the heart of it, it's just making communication improve through communication with that technology. So, with that in mind, if you look around the university in Huntsman, you'll see lots of examples of telemedicine. both here in Salt Lake Valley, and I'll give a couple examples from around the country. The burn center here at the UofU, I think they were kind of in the forefront. Dr. Sappel in 2004 got a grant to study telemedicine and its effects. Before 2004, Dr. Sappel was flying up to Idaho, I think monthly, to see clinics and treat patients before he had this grant came on in 2004. In 2009, Dr. Lewis and Dr. Sappel published a paper in the Journal of Trauma that compared the outcomes of the effectiveness of their telemedicine program. What they did was they put between 300 and 400 miles away, one little cart, it was a video cart back then, in there's two in Montana, so they had 3 locations in frequent transfers for burns. And they just studied the effects of having the ED call here at the U to the burn center when there's a patient in before they transferred them down. And so in that 2-year period, these 3 EDs called with 70 patients. They did a case control to match it. Previously, prior to this availability of this video, 100% of those patients would have been transferred down, 100% of the 70. After they implemented this system, they cut it down to 31 out of 70. So only less than half, 44% of patients that are calling the transfer center with burns now after this program are getting transferred down. Huge savings to the hospital systems for transporting patients, and a big burden off the patients, both financially and socially, to just stay where they are or drive down themselves if possible. The burn centers expanded their role over the past decade. They have over 40 sites in 6 states where EDs call with burn patients, where they say, should we be transferring this patient? Yes, no, okay, either not at all or in a car. And so it's a big help. As an example, just last week, a 12-year-old girl, from Driggs, Idaho, burned her hand. Not a very extensive burn, but in 2003, this burn would have been transferred down by air to the burn center. Instead, the burn surgeons here were able to look at this over the phone, and have them read the wound, have them dress it, give them the dressing instructions, and the burn team will then follow up by the patient has a little app on their phone so that they can call from their clinic every other week or so and check the progress. If the patient doesn't need surgery at all, they'll just never come down. So expert level burn care from 350 miles away, and the patient never even meets the surgeon, never comes down here. Saves transfer costs, saves a lot of time and effort and hassle and money. If she does come down, she'll come down in a personal vehicle instead of getting flown down. So I think it's a really awesome system they have, and Burn's uniquely qualified to be doing this. This is a picture of their setup. The picture on the left is a picture of every center that they have one of these carts in, every ED across the region. And they're actually, the physicians here is kind of onerous. This is still kind of a new process, but the physicians insist on being licensed and certified in each of these facilities in every of these states. It's required that they be licensed in the states, but for billing purposes, they're getting certified at each of these individual hospitals, which is a logistical nightmare. But I think that's going to be improving in time. And on the right, this shows the computer they use to see these consults. It's just a regular desktop computer that any one of us have in our clinic. And it can be if anyone has a similar computer, they could outfit theirs similarly. From this computer, they can see both those carts. You can see the carts that the EDs have in those locations, or they can call patients directly in their home if they would like. The UTS team has a pretty robust. Back here, when you search acute care surgery, there's a picture of me that's from that video that we do every Tuesday. The UTS team has a pretty robust system actually for telemedicine. One thing they do is they see inmates at the local prison. It saves transfer costs. We actually schedule quite a few surgeries without ever having met these people. Hernias tends to be simpler things, but it saves the patients in the prison and the hospital with trouble with transferring these complex transfer patients in and out of the hospital, and then they come in for same-day surgery generally. Just like the computer in the burn center, this computer has a mic and a camera. There's an app called Video. There's a couple of different apps that we can use. This one uses video. And you can see in the picture there, there's a little bed on the left of the screen. Patients come in and get handcuffed. There's a nurse that you can see there on the right who will do our physical exam for us, report findings to us. And then you can speak with the patient. It's a pretty good system in terms of remote care. So the nurse has a little handheld camera for close-up if there's some kind of concern for seeing something fine, we can show us closer to the, but overall it works, and we tend to book surgeries that way. Another example that the use team has given us is this emergent surgery follow-up. This is actually published just this month in the American College of Surgeons. This is a follow-up program that they've implemented where patients that have emergency surgery, so appies, coles, emergency hernias, follow up via questionnaire. And if they're an appropriate patient and not having any trouble, they can actually skip their follow-up altogether. For these patients that might have been clogging up and coming up our clinics are now not following up in our clinic at all, just over the phone. So in this study, there was 402 patients identified as possible that might have to follow up. 68% of this group avoided follow-ups. And they found that it was safe. There was only one major complication in this group of 402. There was some minor complications in there, but major complications, there was only one. It was an intraabdominal abscess after an appendectomy. And that patient was identified on the telephone and brought in. So it was a low-risk, successful program. And you kind of see, if you search the literature, pretty much is kind of a, remember when, I guess, robots and laparoscopy was first coming out, it was, we can do this with robots, we can do this with robots, and it started, you see a lot of research along those lines. You're seeing that in the ortho community especially, but pretty much every surgery they're coming out and saying you can follow this with telemedicine instead of having people come to our clinics. I think most of us know that Dr. Kimball started the tele-ICU program here in the University of Utah. It allows for remote ICUs in the region to benefit from the expert ICU staff we have here. If you search for this around, you'll see these small hospitals throughout the region, kind of most bragging. I think we have this brain wealth now. We're tapped into the University of Utah. They're telling their local communities that we can provide this care, that it's the same level of care you get up at the university, which I think is kind of neat. And then this around, this is the array of services that we're starting to provide here with telehealth. About a couple of team, the derm team, this virtual visits and virtual care has been backwards, but essentially urgent care for urgent primary care visits. So it's starting to get quite robust as we're starting to get more and more activity with this here. Aside from burn and plastics, the surgery is not really well represented. Across the valley, outside of the use system, Dr. Ott is, I think, a great example of someone who's been thinking out of the box for quite a while. If anyone doesn't know him, he's a pancreatic surgeon over at IMC, and he's hyper-focused on patient experience. He won't let his patients wait in the waiting room. He makes sure that if you walk around IMC, you'll frequently see him pushing his patients around the hallways. He's very, very focused on them having a great experience. More so than most anyone I've worked with. I've done more than one patients with him, where the patient never meets Dr. Ott until the night before surgery. He looks at the scans, labs, coordinates with their primary care provider, has them come in the night before, and then he does a ripple the next day. And then he has 100% of follow-up from afar as well. It makes you a little bit nervous, but he's really focused on the patient having a good experience. The most recent one I did this fall was a lady that lived in Durango, a 7-hour drive. I think it was 400 miles, that she only had to make once instead of 3 or 4 times if she came in pre-op and post-op and all that. So I think that's a really, even without the video portion, Dr. Ott's been doing this for a while. And then the competitors across the way to the array of services I was talking about, Connect Care is the IMC version of the UConnect. So both of these systems essentially, they'll let you see a provider, essentially like urgent care. It's a flat fee, it's $50, $60, something along in that range. Your insurance will cover it, covers it, if not you pay a fee. And you're seeing a patient you're seeing a provider within a few minutes. So it can save you from going to the ER, it can really de-stress the system is the idea. That kind of, moving further away from Salt Lake, Stanford has this system called Online Second Opinion Program. Again, it's a flat fee, $700. You call them, tell you you have a cancer diagnosis, you'd like a second opinion. They do all the legwork of getting your medical records, and they have a little mini treatment planning conference, and write out an email with your instructions of what they would recommend. So for about the cost of a person or two flying round trip to California and staying the night in a hotel, you get an expert level insight. And this is a growing thing. If you look for this, if you start looking for this kind of service, the University of Colorado has a similar program, MSK has one. MD Anderson, I saw had one for path review. I didn't see one for the overall review yet, but it's starting to pop up around the country, this idea of online second opinions, where people just want to tap into the physician's brain without having to wait to be seen or go through the trouble of being seen. I think it's a neat idea. The VA is really crushing telemedicine. In 2019, they saw 99,000 individual patients via telemedicine. They logged almost 300,000 encounters. They have some data that's going to be published here shortly that says they're really cutting down on overnight stays by doing this. Instead of having patients come in and do a visit to the clinic or what have you, they're cutting down on the number of heads and beds in their facilities by reaching out to their patients this way. In 2018, the reason there was such a big jump in 2019 is last year, or I guess a year and a half ago, there was a law passed that said that the VA providers can see someone in any state. So if anyone in this room wanted to try to see someone up in Idaho, you've got to be certified to practice in Idaho. VA does not have that restriction any longer, so it's really opened up their capacity to see patients around the country. And then, just as another, this is kind of a growing, popping up trend. There's more, but these are all businesses where if you want to see a provider right now for, you've got a cough, essentially an urgent care. There's dozens of places that will see you online for a flat fee. They say they'll take minutes. You'll be seen by a provider who's licensed in your state. They'll be able to send you a medication to your local pharmacy. And in the time it would take you to drive to our ED or our urgent care system, you'd already have been seen. So it's an interesting service. If it's the middle of the night and you don't want to go to ED, it's a tempting service to use. So yeah, no wait time, no drive, upfront pricing. As someone who recently took his child to the emergency department or urgent care, I guess, to be seen for a pink eye, had I known about this service, I probably would have done that instead, to be honest. It saves you from sitting in a waiting room with a bunch of other sick kids, and my insurance might not cover it, but $50 is, at least I know the price and I know what I'm getting, you know. None of these businesses have stepped into the surgical realm. There is one that I found where you could see a surgeon in this style. University of Pittsburgh has a program where they're willing to see you for a small set fee and give you just essentially chat through your problem and your options. Limited because you can't do physical exam, but they're starting to offer this service, so it might become a coming trend. So why should we care about this thing? Anyone who isn't doing this already could be sitting in the crowd kind of shrugging at this, saying, you know, I've got people knocking down the doors trying to get to my clinic. I'm having no trouble filling out. It's kind of gimmicky. This is weighing it or bowing down to pressure from patients, and we probably shouldn't be doing that. And that's certainly something you could say, but so why should we care? I'd say it's what they want. If you look at the younger population of the Gen Zs and the Millennials, there's been recent polling that show, there's a recent Harris poll that surveyed 2,100 adults. Millennials, 11% of millennials are willing to switch providers if a provider is willing to do this, see patients on telemedicine. 64% of all patients surveyed said they would be willing to see a doctor online. Only 40% of the people over 65 said they would, but people younger than 40, 75% of them would. So, and then a big push and a big desire for the younger crowd as well is to be able to see all their labs, imaging, and notes on a digital app. It's a big request from the younger people as well. So, there is some, there's some thought here though. Over almost 70% of people in any category says they would not want to be seen online for abdominal pain, for instance. So this isn't across the board silliness that people seem to understand that there's a time and a place to be seen by a physician. But for better or worse, this crowd that's less than 40 wants to be, they want your ear, they want to be able to talk to you rapidly in some fashion. So why else should we be considering this or care about this trend? Somebody else is going to do it. This is going to be a growing trend, and it's going to be siphoning patients and sucking patients into a system. I feel a little bit like silly putting that in, like why should we follow these jerks over here? But it is going to be done, and it's going to be done well by someone who cares about it, or it's going to be done by your competitors who you don't know their motives, I guess. The reality is patients want quick access to physicians, and they're going to get them somewhere. I really kind of hate to think of medicine as a business, but it is. There's business aspects of it. This is giving customers, their patients, but their customers, what they want, and what they want is access to us in this manner. If another provider is offering to see patients today online or rapidly online, and you're telling them it's going to be a week and a half, you're going to start losing patients as this younger generation gets older. So we all kind of know the pitfalls, but I'll go through them. Remote care is not a panacea. It's not easy to do, and it doesn't fit nicely into a lot of practices. Obviously, physical exam is lost in telemedicine. It kind of goes without saying, but you're not going to be able to examine patients remotely. Even things like that you think you might be able to, like a skin lesion, is not easy to appreciate over even a nice camera. At least not quickly. Even a total body skin exam would be a nightmare, I think, in this situation. But a lot of what we do, let's see. So that's the big reason surgeons are going to never fully be able to get all the way into this model. Any solution that we incorporate is going to have to have some way of doing a physical exam. Questionable care is the big one. When you're trying to be seen rapidly, you're giving up what we have here, the experts in the University of Utah, quality. One of the biggest pitfalls is going to be this. There was actually a study just done last year in the Journal of Pediatrics that showed that the antibiotic stewardship is pretty awful in this scenario, actually. There was a retrospective cohort study done by a large insurance provider where they looked at 4,600 telemedicine encounters and compared that to urgent care and primary care provider visits. And the antibiotic used for upper respiratory infections in the telemedicine group was 52%, so telemedicine included food, and whereas primary care providers is down closer to 30%. So antibiotic stewardship, these people that are providing this care currently aren't following recommended guidelines for prescribing antibiotics. It's a little bit, you could say that's because they're not being able to see the patient and be reassured, or they're giving the patients too much of what they want, access, and then just following the will of the patient. HIPAA compliance is, I think, a little bit feared, but it's a real thing that we need to be concerned with. A lot of the apps we have on our phones right now that I could call you with, I wouldn't be able to talk about medical things, I wouldn't be able to provide medical services. So whatever solution you come up with has to be HIPAA compliant. Working remotely or seeing patients remotely introduces this difficulty of licensure. If someone comes to my clinic from anywhere in the world, I can see them under my license. If a person just lives 2 miles into Idaho, say, or Idaho, I could see them because I'm not licensed in Idaho. So it's a little bit frustrating. There's some legislation and efforts to minimize the effect of this. There's something called the Interstate Medical Licensure Compact. It's an agreement between 29 states where they're starting to recognize licenses from other states. It's not perfect. It's actually a little bit expensive if you start trying to scoop up multiple states. It's $750 for your first out-of-state license, but it is a way that you can start getting recognized, like having reciprocal licensure. And then malpractice. You have to be really careful in this setting. There's 50 different states, and if you're practicing medicine in a different state, you have to understand the liability and billing requirements. It's different wherever you go. There's some efforts underway to kind of simplify this, sort of how the VA is done, but it's all in its infancy and it's all kind of a wild west. There's like websites that try to guide you on how you can practice in different states, but it's not easy. And as an example, there was a psychiatrist in 2005 in Fort Collins, Colorado, saw a patient in California, prescribed an antidepressant, and 2 months later the patient committed suicide. That physician did 9 months in prison for malpractice because he did not practice, and he was not licensed to be practicing in California. So kind of an extreme example, but it's something to be aware of. And billing is one that's in a huge state of flux. It's really tricky to get paid right now for this. Medicare in this state will pay for it. Some insurers will pay for telemedicine, but it's a very hard thing to do and to understand to navigate the waters of it. I'll go over a little bit more about how the Huntsman and the U are trying to mitigate this, and some of the efforts going on, but you should almost expect to not get paid for telemedicine for the next few years. I'm told by the IMC and the billing folks here that that's going to be changing soon, but I'll talk about it in a second. So the how, I'm going to end up with how to, if you're at the university or the Huntsman, what you should be doing. So there's a whole office, a team that's set up for surgeons or physicians to get set up for telemedicine. I'll put up their contact information here, but for no cost to you or your clinic or your division, they'll come to your clinic and set you up on a computer with the software you need to be connecting with patients. They'll train your staff on the best practices on how to arrange your clinic with these patients, and then show you how to integrate with Epic for notes and all that. There's two software which are, I'll kind of skip through that. There's 2 sets of software you can have on your computer. It kind of depends on what you're trying to do and how you're trying to see patients. But a natural progression that this team is having people do is start with post-op visits. There's no billing to be concerned with in the first place. It can already be done over the phone. So adding a video component only makes it easier. Next, following up with existing patients, say like a cancer patient who's a couple years out from the surgery, who's saying your scans. Question mark. If you're comfortable seeing patients in that manner, if you think that they're being seen by their primary care or their oncologist, then it's a reasonable thing to do to go there next. And then new consults. I think eventually we will see new consults. We do see new consults in the youth clinic in the prison. I think the younger crowd of the country wants to be seen this way. If you have a consult to be seen by a physician, by a surgeon, you're going to want to talk to someone not 2 weeks from now, but 2 hours from now if you can. It's a big ask, and it's hard to arrange your day or arrange your schedule to start doing that, but it's what people want. Whether or not we can do them, that is the question. All right, so billing. So this is such a new field, and the kinks are getting worked out. I spoke with telemed billing at IMC and also the telemed billing here at the University of Utah, and they're trying to shield us from having to think about it. They're pretty confident, the hospital systems are pretty confident that it's going to come. There's legislation being pushed by both groups into the University legislature, the Utah legislature, that will mandate that insurances pay for this type of billing, for this type of encounter. So the university, Huntsman, and IMC are all pushing to just make this happen with the understanding that they'll be the first that are doing it, and it'll be kind of set up when the money starts coming in. So currently Medicaid pays for this, the university hospital will pay for these encounters, so the university insurance will pay for these encounters. Something else that they're, as a way to encourage us to ignore this, the university, currently IMC will give providers or credit providers RVUs as if they're getting paid for it, even though they're not. IMC is doing that currently. The university and Huntsman are trying to go that way. It's not officially approved yet, but it's a push. So, let's see. And then potential downfalls of the system as we have it set up. I really see one. There's no mechanism for seeing an urgent patient. I can't page me, and then I go just talk to them on my phone or on the cart that's in our clinic. Yeah, it takes a schedule to make an encounter. It's kind of a hassle in that regard. So a little bit of work to do for our system here. If anyone is interested in talking to these guys and at least having your clinic set up so that you have the capacity to see patients, this is their contact information. I'll come back to this slide if you'd like. And then just some of my final thoughts. Telemedicine is going to be growing, it's coming. How it looks and how we're interacting with it, how patients and us interact is evolving. I don't think we should be doing remote surgery as this picture implies, but it can be useful. It is useful for some people currently. Anyone who's interested in this should start by just reaching out to telemedicine and trying to think of ways that you can use it, because I think it's coming. That's it.
Thank you, sir. Quick question. So you mentioned reimbursements and RVUs. Is 30 minutes patient visit in the pure clinic personally versus a 30-minute telemedicine visit? Is that used the same RVUs of reimbursement, or is it used in pure because there's no visit?
It depends who you ask, and it's all kind of in flux right now. So right now, it would be counted as just a normal 30-minute visit is how you probably choose to visit that. Insurers want to reimburse that less because there's no facility. Patients aren't utilizing the facility. So it's being debated, and it's really difficult to try to figure it out. Currently, there's no difference in billing. If a patient goes to an outside facility, say an ER, and consults us over one of those carts from an ER, the facility where they're at gets the fee for the facility fees, and the physician that consults from here gets the consult fee, and it gets divvied up that way. So the current norm is shaping up. But aside from that, there's no answer to your question just yet.
So Jim, thank you very much. That's terrific. I actually definitely want that slide, so if you don't mind sharing. What you're touching on here is disruptive technology that will disrupt how it is we traditionally do things. I think everybody here is sitting here having, at some point or another, a visceral response to what's going on. But then you also reflect on how your practice has evolved. And most of us already do this. We do all of our follow-ups. Julie's sitting right behind me by phone or so on. So it's happening. And I think we have to embrace this. Now, the other thing in embracing of disruptive technology is you have to think about the implications of this. That I think everybody is probably sitting here thinking about reimbursement and protecting what's mine. There was a paper published 2 weeks ago in the New England Journal, a summary of the RAND Corporation study that was solicited by the Center for Medicare and Medicaid Services to study the true value of a work RVU for surgical specialties. And in that valuation that is carried forward how we've all been paid for decades, is a component of follow-up care, in-person follow-up care. And what that evaluation study done by the RAND Corporation did found that roughly across all surgical specialties, the work RVU is overvalued by 20% because we're not doing in-person follow-up care. Now, the good thing is we have completely ineffective leadership when it comes to healthcare reform. So it's hard to know how long that will take to get. But as I think about this, we're going to have to accept that the payment structure is going to look different, and we're going to get paid less than what we currently are. And what are the implications of that? So I don't mean to scare everybody, but that's what's coming. And general surgery for all of us in the room looks a heck of a lot better than the other specialties who you know they are.
Right.
We're being tremendously overvalued for the work that we're actually doing when it comes to the follow-up care.
Mm-hmm.
So as I think about our successes in decanting patients out of our clinic, there is a potential implication of that that's going to have meaning.
Sure.
Perhaps this is a chance for another argument that we should be really well aligned with our healthcare system when it comes for payments as opposed to competing for dollars. I don't know. I should think about this a lot. But thank you. This was terrific.
Neelish?
Great talk, Jim. Thank you. You briefly mentioned HIPAA. I'd love to get your thoughts on, whether you think it's actually necessary to have a HIPAA compliant platform for just a discussion. If you get a phone call from somebody in a different state, do we really need to be, being a dying horse with HIPAA if, I don't think the Russians are listening over the phone to, this information, and whether HIPAA is going to be something that's actually going to get in the way of this.
Yeah. Yeah, when I started getting excited about this, I was like, I have it in my phone, FaceTime. I can call people, and you start looking into, can I just use FaceTime? And the answer is no, so far. I was going to include more, but I ran out of time. But we don't need, the reason FaceTime is not HIPAA compliant is because there's no business, it's called a BA, a business agreement, something.
Business services agreement.
BSA, business service agreement, between Apple, and they would need to make a contract with every hospital that intends to use their platform to communicate with patients. If they're going to try to do the BSA, you're required. And Apple's apparently not interested in doing that if they can't really gain them. It seems like a lot of work. That said, you don't need a BSA for the telephone. You don't need a BSA to use your iPhone to make a phone call. You don't need a BSA to use FedEx or the post service. There's something called a conduit that you can use to communicate with patients that that says if you're using a conduit, a system that's protected through and through, you shouldn't need HIPAA certified BSA. I think if someone, a university lawyer, someone cared to make that argument, I think it holds water. I'm not a lawyer, but I think you can argue that FaceTime or Skype or any of those is nothing but a conduit to the patient. The fact that the BSA is not there is, I think it's irrelevant, but I'm not a lawyer, so I'm probably not listening to me.
Thank you. I want to echo what Dr. Glasgow said. This is clearly a disruptive innovation that needs to be paid attention to. But I'm one of those people who's having a real visceral response.
Yeah.
Right. So as you know, I love spending time with my patients, and I'm concerned, and I wonder what your thoughts might be. This kind of represents to me what's happened with the EMR, putting more and more distance between us and the patients, and that loss of that contact, and the impact that has on physician satisfaction and burnout. Has anybody looked at that?
I haven't seen a study on burnout or satisfaction. I've seen patients are satisfied. I don't see anyone caring what we think. But to answer your question, I think the communication is a very important thing. I think your communication is a little more delicate than some of the other physicians who are doing more simple procedures. But it's still, I think this can add to your communication. If someone wants to have a discussion with you about the results and you want to have a face-to-face, it's a seconds away, no matter where they are. If you think of it as a tool that just helps you reach out to patients and have a face-to-face discussion, I think it could be useful for them. But I can definitely see your point where if that's not how you like to communicate, this wouldn't be for you.
This is a great opportunity for a study. What physicians feel is of value in their job. There's this concept of employee surplus, which is what you get paid over what you're willing to accept. And if you've got a crappy job, your willingness to accept is a high dollar amount. The difference is what you perceive as the value derived from your job. So is this actually better from a provider standpoint, or is it going to make things worse? You know, a lot of us celebrate that moment of appreciation that the patient expresses to us. I love the fact that my clinics are decompressed, but I've completely lost that personal contact with all of us. So that would be a terrific thing to study.
No, I think to your point though, we had a huge snowstorm this week, and clinics are half empty because of the snowstorm. And what were the costs to the patients who already took time off of work and then couldn't drive down? Our costs for trudging in here through half a foot of snow or whatever to empty clinics, the nurses and the HCAs and so forth who piled on tracks to get here, when all of that could have been addressed with technology. So I see this not just from this is convenient and so forth. I see this for where we live and for the environment that we have to respond to, but this is something that could be very, very helpful in those situations. So if your patient needed to talk to you that day and it's a blizzard and they can't get down from Idaho Falls, we can still
I think we should study it, and we have a couple of groups here who are heavily involved already, and so that would be a great thing to do. I've gotten to tinker with this just a little bit through the VA, which, as you said, has some lower barriers in some way, which is really nice. Mm-hmm. And for the particular visits that I've done, which have actually been initial reflux consults, I'll tell you that it's much more satisfying from my standpoint to tell the patient they are obese and need to lose about 20 pounds before surgery in Montana over the phone, and rather than having them fly down to my VA in Salt Lake to tell them that that's my opinion up front. So in some ways, I think it can be rewarding for the physician to know that it's a lot more convenient for the patient, depending on the context.
Getting back, not a naysayer, because I see this both ways as a patient and a provider, and which is if you want care, you want it now, you don't want, and your willingness to accept less to get it now, sort of the age we live in. But I'm trying to entertain limits on doctor-patient relationship in terms of questions, repeated phone calls, interactions, calls outside of business hours that go on and on and on with the small minority of patients, but opening up something where you can be available. You brought up the thing about not being able to have an acute phone call, telemedicine, consult. There are some things where there has to be some education. It's so easy to do almost anything using technology, paying for things over the phone, going to different, ordering food, all that stuff. But medical care, there are some aspects of it where it's hard to educate the patient about what's appropriate to be seeking care about and what's not appropriate or the time available. But it gets back to burnout, right? You're available 24/7 for phone calls at any time, telemedicine consults anytime. Can you imagine what that looks like over time?
Yeah.
Over a couple of weeks. And just try to figure out when do you say, like, look, you can't call 5 times about the same issue, even though you're willing to maybe pay a few dollars for that, making those things. Those are things that we have to address within our own practices.
Right.
But Monday's a perfect example. I looked at my schedule and said, I don't want this person driving from Wyoming to talk to me today about this or have this. They don't need to risk their life to drive here, right? But they'll do it anyway. Right? So it'd be much better if we had this technology readily available, which we do.
Good morning. So, as an anecdote, because I gave pretty much this exact same talk at the college meeting last week. Several friends that work for the IMC system, they're internists. One's a medical intensivist, and their ICU models that they sit in the bunker for 12-hour shifts. but I can guarantee you he has Rob, what was the term you used? He is not very satisfied with the differential of that care experience with what they're paying him for.
Right.
You know, they shoehorn the medical intensivists to staffing their continuous care model of tele-ICU. Sounds like a miserable job to me. If you look at the IMCs, because we've had this issue in some of the surgeons that we're trying to recruit, their spouses are hospitalists, and looking at the jobs that are available in the Valley, they are actively recruiting people, internal medicine doctors, to staff the app at IMC. 50% of your time is sitting in front of a screen and answering phone calls, like Dr. Hinstrom probably mentioned. You know, they pay for the service, and like, oh, my toe itches, better call my doctor. You know, that's maybe good for the hospital system because they can charge for that. But I'm pretty sure since they haven't been able to fill the jobs that no one really wants to do that.
Yeah.
So that may be an area to look at as we look at competing and getting market share and attracting patients to our system. And who's going to fill that role? Is it physicians? I'd like to think my time's a little bit more valuable than FaceTiming, you know, all these questions because we operate.
Right.
But is this something that, you know, we could hire APCs for or other providers for to staff this sort of stuff? Because we're going to have to do it. Because that's what's going to be. Anecdotally, the job satisfaction with a lot of this stuff is not. That's what I hear from people.
One more.
Quick one? No. Okay. Offline discussion. All right. Well, thanks for the presentation. Okay, so clarification for ski days. Dr. I had received word, Wasatch Sugar House. The downtown crew is not available this year, so we're in Sugar House. And we'll have like 6 more emails coming down Friday to confirm that. If it's the wrong place, you didn't hear it from me. Yeah. All right, 5-minute break and education.
Okay, let's get started with communication. Okay. A 47-year-old lady comes to see you in clinic complaining of abdominal pain. Sure.
So if you go with the differential or go with the history?
Well, you need to do your history before you can generate a differential, I would say.
I would generate a differential and then make a history based on
Abdominal pain is going to be Satiston, so.
Okay.
Start.
What is my differential?
Your differentials in the textbook.
So I would do history. So I would start with the course of the pain, what it feels like, where it's located, has she had it before?
Okay. Site onset character radiation associated symptoms,
Yeah.
finding exacerbated severity. Okay. She's had it before. She's had it for a couple of years. Rated right here. It was initially a gradual onset. Now she has it all the time. She describes it as burning pain that radiates through to her back. She feels nauseated with it sometimes. Doesn't really vomit. It says that it tends to get worse with pain. Pain medication makes it a little bit better.
But it gets worse with pain?
It gets worse with eating.
With eating, I'm sorry.
Medicine gets worse with pain. And narcotic pain medication makes it better. Any other questions you want to ask?
So I would take a full history. I mean, I would do a social history. I would ask to do a history of alcohol use.
Oh,
smoking.
she's heavy drinker.
I would ask if she's ever been diagnosed with pancreatitis.
She has.
But I would still, I think, ask about like what types of meals she's eating and if there's a type of meal in particular that precipitates it. I would ask when
Mainly
she,
drinking. Those are the meals that she's eating. She just drinks at meals.
I'd ask when she's last had imaging done, and then I would ask if she's had any jaundice or yelling.
No
Jaundice.
jaundice.
We're gonna pass on.
I'm sorry.
I'm gonna pass on imaging.
Okay. We talked all about these things. Feminine positives, important to ask about biliary symptoms. Important negative. Now you're generating the differential. So she's already told you she has pancreatitis, but that doesn't mean that it's just one thing, right? So still a couple of things you should exclude.
So if she has not had any hematomesis or I would be more inclined to figure chronic pancreatitis over like a peptic ulcer disease. Sure. If she does not have a history of GERD, and then pertinent negatives related to biliary findings. So if she has not been jaundiced, if it is not precipitated by fatty meals, if she's had her gallbladder taken out.
Weight loss, important one, family history of any conditions, cancers, perhaps. You think it's chronic pancreatitis, but there's a whole host of things that jump into that. So she may have chronic pancreatitis, but she may have other complications associated with pancreatitis.
There are other things that cause abdominal degradation.
The things that go along with pancreatitis that you include?
Yeah, so I mean, the complications of chronic pancreatitis. So when you're thinking, like, could it be a splenic vein thrombosis, pseudoaneurysm, pseudocyst?
Could it be something else, as Dr. Vago was saying, right? Is there something else that radiates to the back that she has vascular pathology?
I guess what I'm thinking is there are sequelae of chronic pancreatitis.
Sarah?
So does she have exocrine insufficiency or endocrine insufficiency?
But Dr. Mulvihill wants a question, so. Okay.
How would you get at somebody who has exocrine insufficiency? That's a easy one question.
Like digestive issues, that like stools that flow.
Alex, physical exam on this patient. Anything you feel like looking for?
Yeah, so I look at her skin, look at her sclera. I do lymph node exam, probably cervical, cervical, periumbilical, lymphadenopathy. I would, of course, do an abdominal exam.
L here is monthly.
Starting over, I would.
I definitely could tell it was you.
Starting over, I would look at the patient's skin. I would evaluate for jaundice. Look at their sclera. I would palpate for lymphadenopathy, supraclavicular region, cervical, periumbilical. I would, of course, do an abdominal exam first by looking at the abdomen, seeing if it's distended or if I have, sufficient for ascites. I'll palpate, see where her pain is. I would see if I could feel for like a bounding pulse in her abdomen too. I'm gonna do pulse exam, femoral pulses.
Okay. What if she had like fatigue everywhere? And she said, I bruise really easily. I keep bumping into things and get all these big old bruises everywhere. What does that mean?
Liver dysfunction?
Okay. Yes. Why?
Oh, due to vitamin K deficiency?
Right, absolutely. So if this patient really does have chronic pancreatitis and has obstruction of the biliary tree as well, which we'll talk about, that is another thing to look out for. Okay. Tyler,
Yes.
what do you know and why?
What do I want to order? Is that what you said?
Yes, in terms of labs, not for breakfast.
Okay. So this patient, given her overall profile, if I were kind of doctor contact at this point, I would get a full set of labs, including basic CBC, CMP. There's a couple. I would also get some coagulation factors if she has in this kind of, PT-INR, and then also I would consider, just as part of the broader approach, getting some other like fat-soluble vitamin tests as well. Kind of see what her nutritional status is and absorption factor on that. And that's where I'd start from labs. If that we could order that, and then
Just stop. Sports, so just stop. Wait for your results.
And they may press you on you kind of glossed over the vitamin sort of thing, because.
Sure. Which ones? What are you worried about? And I don't know what vitamins are.
Okay, so the fat-soluble vitamins are A, D, E, and K.
Out of the ordinary, he'd have to have a real special reason to want to do that, I would think. So let's just try to be practical on the exam, just what you do really in a clinic visit.
There are only 2 other labs that I would order. I agree. I probably wouldn't get any of this other stuff because it's not going to change, right? If she has clinical evidence of exocrine insufficiency, you can treat that. You can replete things. There are only 2 other labs that I would get because they may change your management. And I specifically ask why, because in my mock oral boards from a couple of weeks ago, I did not order them, and faculty kindly made the patient do things that I didn't look for. So you still don't know what the diagnosis is, right? You still haven't ruled out some things. So what potential 2 other labs could you order?
Sorry, I missed the beginning, but if you're worried about if this patient potentially has cancer, if you want to CA 1999.
Yeah, absolutely. It's probably the only other thing that I would look for. And Alex's exam, she checked the node, she did everything else, so we're kind of, we'll get away from that specific.
You need that before you got imaging?
Yeah.
I would,
I was
yeah.
going to say, I wouldn't necessarily get a CA 1999 before I got imaging. I know where this person, I know what this person has and so forth, but if it's showing up, chronic abdominal pain, history of pancreatitis and so forth, you're going to get basic labs to start off with just to make sure that she's doing okay, and then you're going to think about what sort of imaging you're going to get, and then you're going to base secondary testing based on the imaging. That would be my approach to it.
One thing that could happen on the exam, if you order CA 1999 and the person who's jaundice, right, it could be elevated, but not necessarily related to cancer. So you have to, and then you could end up going down a road that you don't want to go down. Like Dr. Mulvihill said, do what you would normally do in clinic and don't try to overthink it.
And CA 1999 is not a diagnostic test. Right. It's a way for us to help understand what the extent of a known cancer might be, and it might be useful to trend and follow up as you're monitoring the treatment effect. But we know it's inaccurate as a diagnostic test. So.
If only there was some sort of study going on to identify.
Well, no, don't get misled. In clinic, we're getting blood with a bunch of markers because we're trying to show a pattern of markers that is diagnostic, but it's a research study.
So, Jess,
yes.
Imaging?
So I think a CT scan is a good place to start since we haven't completely nailed down a diagnosis. I was going to say for labs, if there's any question in her history that she actually has periods without abdominal pain, it's not constant chronic abdominal pain, I would probably add a lipase just to make sure it's not recurrent acute pancreatitis. But a CT scan will give us a pretty detailed picture of her pancreas and see if there's any changes that would be consistent with chronic pancreatitis before going to something like an MRCP.
Yeah, I think that's reasonable. I think in somebody who has known pancreatitis, getting a repeat lipase in somebody who's got clinical pain, to me, probably isn't as relevant as somebody that's a first-time pancreatitis patient. Being at IMC where we repeatedly trained that lipase, I don't need to know the number. I know if the patient is clinically resolving or not. So.
And they're in your clinic.
Yeah, so they're
At the end of
probably
the day, you're not in the
not
emergency
acutely
room.
ill.
Right.
And they do a period without any pain, and then there's no changes on the CT scan, I'd be much more likely to think, like their pancreas looks pretty normal, then maybe they're having acute recurrent pancreatitis. This is not severe enough to bring them to the ED, but.
Yes.
Yeah, I think the follow-on to that is that we didn't hear, she had pancreatitis, but along the way, somebody must have started an evaluation. And so you start with an ultrasound, wouldn't you, in a 47-year-old woman? And if she's already had an ultrasound that didn't show gallstones, well, then the CT is fine. But common things are common. So if she's had recurrent episodes of pancreatitis and nobody's done an ultrasound, we ought to be looking for gallstones as our first.
She's been worked up previously, so she had an ultrasound. They've ruled out disease.
Trying to do this, isn't it?
So here is our CT scan. Yes, I agree. We would have gotten an ultrasound first before anything. What's that? Anybody?
Mm-hmm.
Then we'll shout at once. We keep going. Micah, say what you see.
So that was a calcification. And then I'm seeing a dilated pancreatic duct, and I think I see the patient still has a gallbladder.
Yeah. Okay. So, what are you going to do next?
Patients in clinic, we're gonna talk about their symptoms, which we've already gathered. Has this patient been evaluated for endocrine, exocrine dysfunction? Are they plugged in with a gastroenterologist for management of those issues?
It's a great question. She has some, but doesn't really complain of any fatty stools. Blood sugars are fine. Doesn't seem like there's anything else to manage other than chronic recurrent stomach.
So I'm thinking about why this patient has pancreatitis, because their cause needs to be addressed.
She's
alcoholic. She also still has her gallbladder. I think regardless of whether she has stones or not, her gallbladder should try to come out based off of a literature review that I did in clinic with Dr. Glasgow.
Hold on a second. For what problem?
For chronic pancreatitis.
But that would be
what were we talking about in clinic history?
A patient with
acute pancreatitis.
Yeah.
Acute pancreatitis and chronic pancreatitis are different processes, and they are going to be approached in different ways. So based on her ultrasound that she had previously and on her CT scan, she has no gallstones. Correct. So
what's the pathophysiology of a chronic pancreatitis?
So that's what I was going to say. So why does she have chronic pancreatitis? She drinks, but why else does she have chronic pancreatitis?
Does she smoke?
She has a stone.
Yeah, she has a stone. So she has the stone it's obstructed.
But then the important part is that stone is not biliary in nature. That is a pancreatic stone from chronic pancreatitis and stasis, causing an obstruction that leads to that big dilated duct, as opposed to an acute pancreatitis patient from gallstones that's just had a temporary obstruction and back up with our enzymes. Yes.
So just going back to that CT scan and the changes that would be consistent with chronic pancreatitis, the stone is there that looks pretty obstructive, and then she has a dilated pancreatic duct that looks like it's the whole pancreas. I don't know if I'm convinced there's a bunch of inflammation in the head that looks pretty normal, or it's hard for me to tell.
It doesn't look too bad.
Okay, just want to make sure. And then I don't see any other calcifications.
No, not a whole bunch of calcifications. She's clearly not having an acute flare. I don't see a lot of stranding around the pancreas.
No,
she's trying to drink less. She's drinking less. She's smoking less. She's reducing her risk factors. But she has pain. And she has this.
So I want to make sure I didn't miss anything.
So what is your next therapeutic maneuver in this person?
So my options are you can attempt endoscopic ERCP-based interventions, stents, sphincterotomy. My understanding is those have been shown to be not as effective as surgery, so I'm not sure if I can start with that. Also, this patient has a dilated duct, so they are, based off of the imaging, they're a good candidate for an operative intervention.
What would you do?
So my next step is I talk about reducing her risk factors for pancreatitis, talk about smoking or alcohol for her, and then starting to assess for her operative candidacy.
What's your overall make a little list, right? I mean, you have endoscopic therapy, which could be hydraulic lithotripsy, okay? Try to crush the stone and extract the fragments. You have ultrasonic lithotripsy, and then you have surgery. You could have a Whipple or you could have a Pustone, right? So you really have maybe 4 choices that are all kind of reasonable to choose from. And I think the debate now is going to be, should you start with one of these less invasive things and try it or not?
What's the overall goal here for this patient? What do you want them to, when you see them 5 years from now, 10 years from now, what do you want the outcome to be? It's not cancer, right? It's not a problem that's pushing them to the hospital right now.
Yeah.
But what are you trying to avoid or improve?
My goals are to avoid pancreatic insufficiency and treatment pain.
What else potentially, I guess?
I'm not sure what you're going for.
So if this patient, I mean, there are different types of chronic pancreatitis patients, and this one doesn't seem to be one of those sick ones, but if this patient continues to drink and continues to have problems, they could have recurrent bouts, attacks, where cystic degeneration of the pancreas can be a problem where they develop fistulas or other problems that or can prolong their chronic pain for forever, really, and make them very ill and require multiple other interventions. So, I mean, this patient isn't as sick as some of the other ones, but you have to start thinking that you're trying to prevent long-term sequelae from the pancreatitis itself, which could cause them to be sick in the future. But, I wonder, this patient got operated on, and you mentioned that there was some effort to reduce their drinking, but they're still drinking, or what's the...
This is more of a sort of bedside evaluation, just looking at the patient. When she says that she's stopped smoking, stopped drinking, but when we met her on the day of surgery, and we walk into the room and somebody's clearly still smoking, looks a little jittery. You just raised concerns about how well or what kind of complications and recurrence they're going to have on top of having a relatively large surgical procedure. The other things we didn't talk about, the celiac access block, the pain. If pain is what we're trying to manage, you look at the literature of how well pain is managed with surgery, depending on the extent of disease, that is a potentially good option as well.
All right, so 3 minutes.
Okay.
So there is literature that supports doing surgical therapy versus non-surgical therapy in this type of patient with a dilated duct. So can you go over that for a bit?
So from what I could find for patients with chronic pancreatitis and pain with stones in the head, but the majority of the disease leading to a dilated duct obstruction, there is reasonably good, at least short-term outcomes in terms of years for improvement in symptoms and pain. But overall long-term outcomes, patients are at risk of after a procedure, specifically Pustone, recurrence of disease leading to the secondary to potential complications if you haven't sewn full thickness to full thickness and there's ongoing fibrosis and essentially restenosis, exocrine insufficiency, return of pain, and obviously sepsis as well, because you've now connected a sterile portion to something that has bacteria in it.
So So there have been 2 Cochrane reviews of this that have been done, that have been compared endoscopic therapy versus surgical therapy, that have both come out in favor of surgery. I think one was in 2015 and one was in 2017. That repeated attempts at doing endoscopic and ERCP type-based therapy actually led to more complications.
Increased septic risk factors because now we don't.
So this patient does have a solid indication for surgery. The question whether they continue to drink or not drink is questionable. In the Cochrane review, they didn't review that specifically. Milos had already mentioned that there is a long-term downside because you've operated on somebody who has a progressive disease process. So with all of that, you do end up doing surgery on this person. And again, the first operation you can be thinking about is doing a few stow. Second operation, as Dr. Mulvihill said, you can think about doing a whipple on this patient.
Just briefly, because we'll get to the pictures, so that we can understand when you choose which operation for which patient. For those of you that don't know, Dr. Nelson, that would have been his question. Who are each of the respective surgeons after who these surgeries are named? I came up short on Dr. Berger. I couldn't find anything. So Cousteau procedure. I mean, this is exactly like a CT scan. Not all these patients have a stone in the duct, but they all have main pancreatic duct dilation. Dr. O'Loughlin, how are you going to do this surgery quickly?
So expose the anterior surface of the pancreas, locate the duct with ultrasound, get some sort of a needle into it, make sure you're getting clear fluid back, 12B down into the duct, and then do a longitudinal pancreatic ojegonostomy.
Okay. Full thickness of pancreas, like go all the way through the pancreas, out through the duct, and then the same thing on the other side. And again, the risks are, like we've already talked about, so that when you're done, it looks like that. Dr. Skates tells me that there's absolutely no reason to remove the stone. It probably increases the morbidity of the procedure because you're digging around in the head of the pancreas trying to take something out when you now have adequate drainage through the rest of the pancreatic duct.
Well, I guess the question is, that diagram is misleading because generally you're willing to send that far into the head of the gland. Once you get to the gastroduodenal artery, you're now in a little difficult territory because the bile duct will at least be another few millimeters to the right of the gastroduodenal artery. So that generally would be the end point for the drainage. But if the stone shows itself as you open the duct, of course you're going to remove the stone.
Yeah, and we did not. When we ultrasounded it, we basically found the complements of the portal vein. The stone was well medial to that. We opened for about 10 centimeters. We didn't go all the way to the tail because I just see the point of, as long as you have a large enough duct, it's going to drain as long as it's sometimes Dr. Glasgow mentioned just do a whipple. I had you. So picture A is a whipple, probably a little bit excessive. What is B?
Well, when would you do a whipple? We're really getting into the weeds here. When would you do a whipple? When do you have to do resectional therapy for pancreatitis?
So if the disease is completely in the head.
Yes, so head-dominant calcifications, right. Generally with a non-dilated, less dilated pancreatic duct.
Because your other option for that is if it is primarily just that, you can do Vega with the burn modification where you don't dissect, you don't transect across the head down into the portal vein. You just do a single anastomosis. So, Sean, what's B?
That would be. So your resectional procedure of the head, coring out the head, so right.
So that one, B is actually the Vegas, right? Coring out of the head, there's a normal duct and there are 2 anastomoses. D is essentially the same thing, but that's the burn modification where they haven't transected down to the portal vein, and it's just a single pancreatic or jejunostomy as opposed to the two. And then C is your fray procedure where you have coring out. Sorry, fry. Shouldn't be. Never mind. I'll let it go.
FREY is the professor at UCA here. He's one of my, Dr. Barber, I'm sure worked with this.
I have. It was in the slide. Coring out of the head because there is stricturing disease there. And from what I could see from Dr. Fry's, he individually identified Dr. Santorini with Dr. Roshan to make sure that was adequately trained and went backwards to the rest of the duct. And it's stenosis, unlike the rest of the duct, which is dilated head predominant disease. You have calcification and stenosis. And
30 seconds.
30 seconds.
Done.
I have a question for Dr. Millennials and for English. Is there a role for screening for pancreatic cancer in this patient?
Well, I hope so.
I mean, chronic pancreatitis is one of the risk factors.
Yeah, it's a risk factor, and that would, but we don't have a screening algorithm that's accurate enough yet. But yeah, that would be a future goal. The reason the Whipple is not preferred is because you often can't dissect the plane between the superior mesenteric vein and the neck of the pancreas. And so that's how the Fry and Baker procedures were developed. But they're kind of unsatisfying because you're really just chipping away at pieces of pancreatic head and always holding your breath that you're not injuring the bile duct.
Well, and you do so until the bleeding gets so bad it just stops. Is the complaints the extent.
My understanding is the benefit to doing the coring out procedures is if you do have the obstruction, you can resect part of the bile duct and reconstruct into your stenosis as well. Yes.
Is it safe to say, beyond like the Fusto procedure, that these other procedures you've mentioned are to be done by people who are highly specialized and have done or been trained to do them? Like in terms of thinking about boards and board preparations, just the limit of what should be expected of a general surgery applicant, I think, stops at the Fusto, right? And if it's clear based on imaging or there was some other issue related to the duct size more proximal to that, that you would be in your realm to say I would need specialized HPV help for this.
I would say that after doing 2 years at UC Davis with Dr. Fry and taking care of probably 20 of his patients in the ICU, I would never do the 5%.
That's when I used to do this. I used to do Fry's. I think you're right, Mr. that if this were to come on the boards, I'm beyond my 1 year limit, and I've done boards 4 times. You've never had.
I assume if somebody asks you that question on boards, you pause and now they're just making up the rest of it.
You should know drainage procedure, and when you would think about intersection of drainage. That's the reason. But you guys also have to clean up the thought process about what the pathophysiology is here. And the other thing that may come from it, if this were a STEM on the boards, is probably going to be a STEM more focusing on, do you get this person to quit smoking? Do you get them to this risk prediction, risk mitigation strategies? You have to think about that.
And you only have 7 minutes
for
this question. So it's either going to be straight to the operating room or it's going to be a workup question.
Yeah.
So,
what is the role of the celiac block? Do we use that for confirmed diagnosis?
I don't think there's much role in chronic pancreatitis. The durability is very poor. I think it's better for pancreas cancer.
Something involving pancreas, but different. So the trauma. This is the page that goes out. So trauma 1 here in 10 minutes, 58-year-old female gunshot wound to the chest. So I was thinking about this in terms of when I'm running down to the trauma bay versus when I'm in the trauma bay. So let's say, and you're running down to the trauma bay, about to run this trauma. What are you thinking in your head? You know where the bottom stuff. We only have the
top page.
Yeah.
I mean, I'm thinking, as I'm running down the trauma bay, I'm thinking about what I'm going to do, say my timeout, because that's going to be the first thing I'm doing once I get there and make sure I have my team together. And the things I'm going to cover in that is, is penetrating level 1, and then run through the,
That's my next question. Go ahead.
I mean,
So let's say you're in the trauma.
things we're going to talk about is, running through the ABCs in my timeout. So airway, who do I have a provider that I trust at the head of the bed based on whatever algorithm they're currently on with that. We're going to have chest tubes up bilaterally and open, or not open, available bilaterally. We're going to make sure we have our central line kits available as well. We're going to clarify our roles, who's going to be doing what. And then we're going to also talk about priming the Belmont, and having that available, who's going to be on that. We're going to talk about briefly fluid resuscitation, what fluid we're going to have available. The trauma attending will be there because it's trauma 1. And, we'll briefly mention, when we'll kind of signal when they're going to pull the trigger on if they wanted to do a mass transfusion protocol, have our products available. And then we're going to, I always end by saying we're going to go through the ABCs until we get that right. And, we're not going to get focused on anything else and clarify who's doing what procedures on what side of the bed. And if I have to step in, and then briefly mention if we have time, if they're not like rolling in hot at that point, if this would become a patient's arrested, briefly touch on the ED thoracotomy protocol, and then I would step in and do that while the attending took over, make sure we have a tray, who's going to go grab that tray if we need it.
Yeah, another thing I'll say is I always have the thoracotomy tray there.
Ward off the evil spirits.
Yeah, and as I'm running down the trauma bay, I'm running over the steps in my head of what it takes, but we won't go through that right now. But yeah, all that's perfect. There's only one thing that I would add to the trauma timeout. We'll go through that in 1 second. But let's say, so you mentioned MTP, which is something that we're all going to have to talk about. Who's on trauma from the interns? Melissa, you want to tell us what the criteria are for MTP?
Sure. So it's a UPIC2, systolic blood pressure less than 90, ED heart rate greater than 120, penetrating mechanism for a positive fast.
Okay, so this kind of,
That can be done by the
this patient before they get here, so technically you can't initiate MTP before they get here, right? But this patient kind of technically already meets criteria. So, got those. This is the other thing that I think is good, and I actually saw a chief bring this up during the trauma bay one time, and go through it as we were running timeout, they say, if the pressure is less than 60, we'll plan on resuscitation and opening the thoracotomy tray. If the systolic is 60 to 90, then we go through this transmucosal protocol of MTP, fast, bilateral chest tube, etc. And then if the systolic blood pressure is less than or greater than 90, then same thing with the exception of they get the CTA. They don't necessarily get chest tube, etc. There's this idea of a transient responder versus a responder. And if you get a transient response, then you kind of go through back to the systolic 60 to 90. If you go, or a responder, you kind of go up to the systolic greater than 90 and get a CTA. So, this is the patient. So they come in, they roll in, she's talking to us, and basically says that she doesn't want to live, but answers questions appropriately, GCS 15, she's speaking clearly. She's got bilateral breath sounds. She's got a heart rate of 75, pulse radial, DP pulse bilateral. I'll say this blood pressure happens, it took him a few minutes to get his blood pressure, but it was 78 over 42. The fast was equivocal, to negative. It was difficult to get the pelvic view, but it was negative in the splenorenal and the patorenal. GCS 15, pupils of 3 millimeters, and the only wound that we found was on the left anterior chest, on the lateral breast. She's not an extremis, and trauma blood is not another depressant. Awesome. All right. So
did the patient just tell you they didn't want your care?
Yes.
Every day.
She was like, I don't want to do this, and tried to kill myself. She was mostly quiet, but she had a couple great times wrong. But anyway, this is.
We'll stay out of the ethical realm, whether we should be doing this or not. Right, so Sarah, what are you going to do? You got conflicting information, right? You've got Marcellus Pettus pulses that are palpable, and you've got a low blood pressure. So which one are you going to believe?
Based on kind of the chaos in the room and the difficulty getting at it.
So I'll say that part of the trauma timeout is I always tell everybody to shut up, stay quiet, and communication goes through me. Yes.
If I've got palpable DP pulses or heart rates in the 70s and she's actually mentating, I would be inclined to believe that's not completely accurate blood pressure and I'd want to get another one, but I would still want to have a rush on having trauma blood in the room. And
Yes, I think these are, I mean, they're discordant for sure, right? On top of the fact that she's got bilateral breath sounds, and we have a negative fast. So I elected not to put in chest tubes for. I elected not to, well, we didn't have trauma blood at the time. I actually wanted blood. But I asked them to run saline into the Belmont, tell me when that blood available. And then I asked them to get a repeat manual.
Which was?
By that time, they had 16 gauge already in, and the Belmont was going in. And
what was your repeat?
It was over 90, so it was, I think it was like 96 over 60.
So now what's her?
so she's got a penetrating injury. She's hemodynamically stable. We have an equivocal fast. I would complete our kind of trauma workup and go to my secondary exam. Do our primary survey.
Yeah, and then so adjuncts on top of that, and call for X-ray, et cetera. Yeah. So secondary survey was negative. We actually did not find the other bullet wound or bullet.
Excellent. You didn't find another wound.
We did not find the other wound. There was a, I didn't mention in a later one that the report said that there was a bullet or a slug found at the scene. So we're expecting that there's another hole somewhere. And then that's our chest X-ray.
And where's the entrance one? Do you think you said?
Lateral breast. I'm at this point blown away.
First, when you say lateral breast, when you like really.
But there's, she has burn wounds around the mark. It's oozing a little bit, but it's not sucking. And like I said, it's a single clear injury wound. The lateral breast.
So you said you mentioned adjuncts. This is penetrating torso trauma. What are your adjuncts? Emily, what are your adjuncts for penetrating torso trauma?
Sorry, what do you mean by adjuncts?
Well, we do adjuncts for our primary survey, right?
Okay.
So
yeah.
fast is one.
Chest X-ray.
And then what else?
Pelvis.
Why would you get a pelvis X-ray in a penetrating trauma?
I guess you would.
What would you get? So this is an important point because we are not a penetrating trauma institution, and everyone says get a chest and a pelvis for penetrating trauma, which is not correct.
That's CTF.
Marcus? EFAST is fast. So an abdominal film, and why do you want to get an abdominal film?
What do you need to decide in this patient? Which body cavity you want to be in? Right.
Do you need to be in a body cavity?
Do you need to be in a body cavity? And if so, where's the projectile? And do the number of holes and the number of projectiles equal an even number? Seriously, I mean, if you get somebody who's been shot 7 times, you need to figure it out. So you want to get an abdominal film. At least I would get an abdominal film on this person to try and see if I see a projectile, see if I missed a wound somewhere, and to try and decide if this patient tanks where I need to make my incision.
Yeah, so we didn't get an abdominal film, but yeah, that's a good point.
Did you say anything about the gun?
It says 38, so I mean,
Let's
kind of curious.
Let's not forget that before you do that, you have to roll the patient and look for other wounds. Okay? You gotta look in the axilla, you gotta look in the perineum, you gotta check the back.
So I'll tell you, we did all of those things and didn't find it. So we checked the bilateral axilla, we checked the perineum, made sure, specifically talking to all at that point, said check the perineum, we rolled her over, didn't find it.
Stokes, now what? He was still hemodynamically in the normal range, responded to her initial resuscitation. Your workup essentially at this point is negative, so no peritonitis on her abdominal exam. Chest X-ray is fine, breath sounds bilaterally.
And she's responded, her blood pressure is normal now?
Yeah.
95.
And she's 95 and actually continues to go up. There's also discrepancy between the cuff pressure manual and the cuff pressure monitor. So I asked them to keep getting repeat manual pressures.
Okay. So she's still asymptomatic. She has a gunshot wound to the left chest. It could go up into the neck, so I'd be looking for any symptoms of that. It could also be down in the abdomen. So if she continues to be hypotensive, I'd repeat my fast.
Okay, she's hemodynamically normal.
Okay. I would get a CT scan.
What are you gonna scan?
What are you gonna scan?
I'm gonna scan her chest, abdomen, pelvis.
Okay.
Neck, maybe scan?
Well, yeah.
You get neck as part of the.
Depending on where the gunshot wound, I would also include the neck, but based on her exam and also the location in that chest X-ray, I'd probably get chest, abdomen, pelvis.
Yeah.
So why didn't you do a KUB or a flat plate with the abdomen in the trauma plate? Why did you go to the scanner?
Do it every normal, and so if you're right, we check.
And so no peritonitis on exam?
No peritonitis, her fast was negative.
Fast was equivocal is what you said.
It was negative in slow renal, and the cardiac.
Okay, so if you had done a plain film in the trauma bay and you saw a bullet in the abdomen, what would you do next?
I was still scanning.
Why?
Because she's hemodynamically normal, and I don't know if it's in the soft tissue of the abdomen, or I don't know if it's in the peritoneum or the retroperitoneum. If she's hemodynamically stable, I don't have a reason to be inside of her abdomen.
Acutely inside.
Correct.
Okay, so
she's unstable. Maybe that's the decision point. She's unstable. It's an abdominal scan or abdominal film with the trauma bay. Unstable.
Well, she should have gotten abdominal film regardless.
So
that's just part of
so
the
there's, you go to the operating room for bleeding, but you also go to the operating room for what?
Peritonitis.
Or hollow viscous injury, right? So if you had determined on plain film, I get the concern that, what if this was a subcutaneous bullet and it didn't even enter the abdomen? I think that's reasonable to get a CT scan if you're worried about that. Had you gotten a plain film and you saw that the bullet was stayed lateral and wasn't even across the abdomen, you could have avoided the CT scan altogether, right? Based on where the hole is and where the bullet is, you draw a line and you say there's no way this entered the abdomen. You could just observe that person. But if you saw it crossing the midline, then you don't know if it's just in the soft tissue, and I think the CT scan is reasonable if you don't have peritonitis.
I think I'd get a CT regardless.
I was going to say, I don't mean to question the trauma guys, but I know we would always talk about the unpredictability of bullet paths and ricochets and things like that. Is that a factor?
It's fair. I've had people where you can see, there's a bunch of soft tissue continuing here, and you're getting a film, and you're like, there's no way. I mean, in somebody with a significant birth, not somebody who's standing there, can still enter the abdomen.
It is that she's got significant birth. So this is for the chest.
Yes.
There it is. Nothing. Just to be. So there's tracking subcutaneous tissue. And then at the costochondral margin, here, there's some kind of air around the costochondral margin of the seventh rib. Then everything you see right there, that I start off with, let's say Molly. This is a super small view, let's say, like right there. Right liver maybe.
That looks like there's some fluid travel.
Yeah. And then what do you see here?
There's also maybe some free.
A big gray blob.
Oh, well, that looks like it.
So that's her
stomach.
This is her stomach here.
Okay, so it looks like there's like a hematoma around her spleen from behind her tongue.
Yeah. So keep going down.
So it's around her stomach and behind her spleen, by her pancreas.
And then what is this?
That's extravasation.
Yeah. So some shear extravasation or some sort of vascular extravasation. And the only other thing that wasn't there that we're going to get around anyways is this right here. So a little bit of free air. Okay. So, and then this little.
Yeah, the posterior contusion.
All this here. So,
keep going down.
Molly, what do you?
Keep going.
Right there. This is the track.
Okay.
So yeah, why? How was it wound missed?
Yes. It was in our fat folds. But
it was in a fat fold?
Yes, sir. But it was missed. We found it after. And we saw this and we said we just have to check it in.
So bullets plus fold.
It evened out. We were concerned on the scan.
You'd have 1 and 0. So yeah, that would make me question.
So Molly, why is? I mean, we did a fast, and I told her splenorenal and her acetarenal junctions were totally normal. And I'm looking at it. This is not me trusting whoever's doing it. I feel pretty confident.
I mean, you could have had interval bleeding between when you did your fast and when you put the CT scanner.
Yeah, good, but probably not that much.
Or it's just not like in a dependent area where you just here.
So how much fluid do you need on the scan? Let's say, like, Mark, how much fluid do you need on in the abdomen to theoretically see how fast?
Okay.
200 is kind of the number that I usually use. The other thing that I'll tell you is you can miss it at the inferior border of the hepatorenal, so you have to scan all the way down to the lower portion of the liver and catch this very tail here. Even that's a really small amount of fluid. I don't know if anybody would have seen that. And then it also depends on the patient positioning when you're doing it. And so if they're tipped, basically reverse Trendelenburg, then you're not going to see anything up high. This also is contained a lot within the retroperitoneum, so it's not completely contained, but a lot of the blood was in the retroperitoneum. So
the purpose of the fast really just to identify. You got to go to the operating room and you want to know what cavity is. You got to know now.
Yes, sir.
And so this wasn't a failure of the fast. The fast did what it was supposed to do, which was to give you some equivocation about that. You're able to get an ancillary test, the patient's stable, and you're able to make a better operating plan.
I think so the hard thing for me is, well, not I think hard for anybody is what if you're in the operator in the trauma bay and the patient is hypotensive persistently, they're going to shot over the chest, they have bilateral breath sounds, and they have a negative fast. I think it's a hard story. So I don't know.
Well, so what would you do if you have a hypotensive patient?
If they're persistent,
a non-responder gunshot wound to the chest with a negative EFAS and a normal chest X-ray, what are you going to do?
Chest tube. So you get the left chest tube.
Blood pressure 7. So you put a chest tube and you don't get any blood.
Yeah.
So now what? Blood pressure 65. Blood pressure
we get fast and it's still negative.
So the fast images are equivocal.
Yeah.
So you can't.
It doesn't matter at that point. If you've got a gunshot wound to the chest with a hypotensive patient, you put bilateral chest tubes in that are negative, your cardiac fast will say you feel confident on.
Yeah. It could be, yes, but it could be theoretically it could be dynamic as well.
Sure. It could be, but if somebody had a gunshot wound to the mediastinum, they'd probably be dead.
Well, and your cardiac fast should be positive.
Yes,
so I'm just saying, the fast allows you to make a rapid decision, more so on a blunt trauma patient than a penetrating trauma patient where you've got maybe a C-spine injury, maybe extremity fractures, and they're hypotensive, and you have a positive fast. So now you might need to go versus pelvic fracture, negative fast, now you're going to go to angio instead. All right. So Stokes, now what?
Go to the OR.
Go to the OR. Good call.
Okay, so let's on a slide rate, you get into the operating room. Stokes is running another trauma that just came in. Dr. Rula says open the abdomen. So, like, how are you gonna start your trauma lab route?
So I would have widely prepped and draped, including bilateral groins, since we don't have any central access yet. And then I would make a very large midline incision for skinless.
So one small point, are you going to prep the groins because you want access?
No.
What are you going to prep the groins for? And I would say not just the groins, down to the knees. Something you want in their leg that you might not. So you prep them for their saphenous. So in case you need a vascular conduit.
Okay.
Because anesthesia is working at the head, you give them neck access. So this patient is prepped from us from the chin to the knees.
And you prep the chest.
So like here, all the way out to the axilla to the knees. Before all this happened, I also think that you could argue if you don't have other place that I was thinking about, it's in the axilla, right? Like the axillary artery injury.
Also part of when you didn't know where the bullet was at first, and you're getting this supportive blood pressure to check both sides.
Yes.
Right? In case you have a subclavian or axillary artery injury.
And so we checked them on both sides, and I was saying she also had a really actually bounding pulse on her left hand. Okay, so 3 minutes. Sorry? 3 minutes. Yeah. So what are you going to do? You got to prep them all the way.
So I'm going to make a very large midline laparotomy incision. I'm going to be talking with anesthesia and letting them know just before I actually enter the peritoneum so that they can prepare for any big shifts in hemodynamics. And then I'm going to pack 4 quadrants, and then I'm going to systematically go through each of those 4 quadrants and look.
Yeah, okay. So she's got most of her blood's in her right upper quadrant. We pack left, right upper, left upper, pelvic bilaterally. We can see that she's got a hole in her stomach through and through, and then we can see that she's got basically a blown out kind of retroperitoneum. What are you gonna do next? Let's say, Travis, what are you gonna do?
So we've opened the lesser sac and you assess beyond that.
No, we haven't yet.
Okay.
We can see it. She's got a
tract
into
giant retroperitoneal hematoma left side.
It's bleeding through. We can actually see like a thin film where her lesser sac
Right.
is.
So the site of bleeding is usually the largest point of the hematoma there. So you need to assess and control that bleeding. So packed the upper quadrants, kind of relieve, suction, dissect down, and figure out where that what's bleeding at that largest point of the hematoma.
So how are you going to get there?
So this is the left side. So going to incise along the left, along the white line results, and reflex the viscera medially, left medial visceral rotation, and just look right there. Yeah, look.
So hang on. So this is a zone 1, zone 2 retroperitoneal hematoma. What are you going to do first?
So I rotated the viscera medially.
You do that.
Exposed and make sure I have control of, or at least visualization control of the aorta.
When are you going to do that?
What's that?
When are you going to do that visualization and control of the aorta?
After
Fuzz.
He's going to do it first.
Yeah, so you do that and the patient starts exsanguinating. So you want to, in the zone 1, zone 2 retroperitoneal hematoma, you don't know about the central vasculature of the aorta, whether or not that she's got an aortic or behind the scene.
Right.
You need to have hiatal aortic control before you open up the retroperitoneum.
So pretty much we took out the triangular ligament, but we also knew that she was bleeding from her distal splenic artery. So that was after we took that down. We didn't actually do clamp across the hiatus because we had pretty easy access to it. But we medialized them, clamp the spleen. These are all her injuries. I think this is basically the bullet went through. You feel through her costal margin, through the diaphragm, through liver. So segment to the liver stomach through and through, distal pancreas, proximal splenic hilum, and left kidney. And then through the retroperitoneal soft tissue. And my primary concern, again, we could see it on the scans that she's looking for distal splenic artery, so we took that first, got control of it. Then addressed everything else.
This patient must have been pretty stable at that point. Would you fix the...
She in the scanner, actually, so scanned her, moved her off the table. And
in the OR.
We actually did TP, and then she...
Because you have to, that's a lot. Yeah. That seems like a lot. So it's
the first thing that we did is we clamped the splenic island, and then we called up, everything was fine. The next biggest injury that she had in terms of bleeding was her kidney. We actually bumped the urologist for this case, so they were standing right outside the room. And they were like, oh, we should take a look at the kidney, which is a whole separate discussion I think we should have. So all these other ones are relatively straightforward. The pancreas, I think, is one of the more complicated ones, but she had a through-and-through injury through her central pancreas. We couldn't visualize the duct, but we had a pretty good idea that it went through the duct, so just a pancreasectomy. And then the other thing is just laying tons of granite, or laying kidneys at least over the pancreatic, the distal pancreas. And kidney, so the kidney is a tough one because mostly what we do is we feel like the standard answer is you feel for another kidney. If it feels normal and you have major bleeding from that kidney, you take that. But then there's, well, at the hilums, if you have a completely shattered kidney.
So G. Moore gave a really good answer to this at the meeting last week before, whenever it was, the Utah ECS meeting, and basically made a comment that using that, there's a kidney on one side, let's just take the other one out, is not an appropriate answer in a hemodynamically relatively stable patient. That evaluating the kidney and doing everything you can to try and preserve even part of their renal function, so doing a heminephrectomy, which was done here, and fixing the collecting system and then putting a stent in is the appropriate thing to do. But what you said is what we would have done 20 years ago, which is, yeah, you got a CT scan, you know that there's another kidney, you know the other kidney functions, so just take it out. That's not the right answer.
Right, so I was reading the trauma book a couple days ago, and that's still the answer in the trauma book. One that Dr. Moore is an author or an editor on. So, but I do agree that there's tons of literature out there now that says that renal preservation, including Dr. Brewer, I think he's part of the LSD committee on this. But I think the big things that make us fail non-operative trauma for kidney injuries are, one of the big ones is just a high grade, and the other one is a penetrating injury. I think early call to the urologist to say, to ask them to evaluate, because I wouldn't have felt comfortable doing an inferior pole kidney section, but they were there and helped Dr. Young and I.
Just to be clear, that's in the stable patient, right? So you need to assess before you undertake this condition rotation. You want to know what their lactate is. Are they hypothermic? Did they have are they acidotic? Have they tried it out? They do, the kidney comes out. And there's no time for renal preservation in that sense.
bleeds a fair amount too. They're not bloodless. This isn't a bloodless procedure, right? So you should see them.
So you're basically, it's called a heminephrectomy or partial nephrectomy, but the bullet does the nephrectomy. So it's already taken out the lower pole, so you just go in and cut it off, and you close the collecting system, and then you close the frame over the top of it. Right? It should take 10 or 15 minutes to do that. It shouldn't take an hour.
It took them a while because they mobilized the mental flap, and but totally stable patient, and
Where was the injury to the splenic artery? You said you clamped the hilum of the spleen and controlled bleeding. So was it really a splenic injury, or was it?
It was the distal pancreas and the splenic artery at the very distal portion of the pancreas. So we clamped the hilum, and I think that just got right over where the injury was. We ended up taking it more proximal because there was a smaller injury more proximal. When we did the distal pancreatectomy, we did a ligation of the splenic artery and everything separately.
How did you handle this pancreatic stump?
The stump or the distal pancreatectomy?
No, how did you handle this? What did you do to the remnant?
So we stapled it with a TA, and then we did pledgeted mattress sutures through basically at the staple. And there's
sealant on it?
We did not put any sealant on it, sir. Just pledgeted mattress.
Okay.
It leaves.
Do you close the patient?
Not this much, no. So left room, left drains in the distal portion of the pancreas, left drains in the portion of the
Did you take her back for a second look?
I did not take her back.
Somebody else.
Awesome. 2 days later.
Just to make sure that. I mean, it seems like a lot of injuries. There's potential for missing something, which is pretty high here, right?
So I think the take home from this is recognizing what's really critical and what's not really critical. So yes, they have a liver injury and you take your ligature and you come through that portion of the liver and you're done. They have a small gastric injury, you can do staple, and that's out. So those things are not, and a diaphragm injury, put a couple stitches in. But the main injury is the pancreatic splenic renal complex, and recognizing that and managing that.
The order that I always think about it is control of the vasculature, control of anything that is hollow viscous, and then after that, solid viscous. Go down.
So what happened?
She leaked. She's in the ICU still. She's
transferring out of the ICU. She did.
No. She has DVT. She did her pancreas. She did not leak for the everything else. Congratulations. Yeah. It's just like next case after.
Real win. Wish you had such a simple wrestler.
And he's like, God damn it. Everyone's dying all around me. Last shift, and I finally got the this way. Ever? You mean ever?